Thanks everyone, and I realise that we're running a bit late and I'm sitting between you and morning tea, so I'll make it pretty quick because everyone now in Australia and New Zealand, every service has a cardiac arrest registry, so it's brilliant, something I'm extremely passionate about. We established ours, Steve Bernard, our medical director, and myself established ours 20 years ago now this year, and we used to call it our love child. And then it was like our petulant teenager, and now it's our young adult. But I couldn't emphasise more that without a registry, you really can't make improvements, and you don't know what works and what doesn't work. So it's imperative, and it's so great to see that every service now has a registry. Oh, what's the forward button? Oh, there, the green one. So I'll just quickly go over some of the things that I see that have been evidence-based value of registries. So they're a really powerful tool for describing healthcare, including complications and benefits of therapies. They really do drive a quality agenda. Without a good quality registry, your quality improvement agenda just really doesn't exist. And they do foster a performance culture. They support more effective, efficient and appropriate care. Knowing that performance is being measured is motivational, particularly for paramedics, and it allows us to provide meaningful data to clinicians, which drives change. And you can really focus on your poorer performance areas, and we're about to do another big mapping exercise in Ambulance Victoria where we'll look at by local government area, our incidence of cardiac arrest, our bystander CPR participation rates, our response time, our AED locations, where our lay first responders are, and really target the LGAs that we need to focus on more. They definitely reduce costs with clinical trials, so all the cardiac arrest clinical trials that we run, we get our outcome data from our registry. They verify if real practice is in keeping with recommendations and guidelines, and monitor equity to access to care, and whether care is delivered in line with best practice. They're relatively inexpensive. I think to do it well you need to have it resourced at least to a minimum, which I would say from a size of Ambulance Victoria, where we go to about 6,500 cardiac arrests a year, you need a good 3 EFT attached to your registry to have it running at a high quality and in a current format. So we usually run only about 2 weeks behind with our data. And clinical trials often exclude patients, so they have very rigid inclusion-exclusion criteria. Using registry data, you can have a look to see the effect on the wider population, and it's a better reflection of best practice. But registries are only valuable if you use the data to measure and drive change. So just using them to report on KPIs is meaningless. You need to use the data and you need to use it to drive performance improvement. So value is really only delivered through improved outcomes and greater effectiveness and appropriateness of care. There was a really good report released a few years ago on the economic value of clinical quality registries, and it's a great report if people want to use it to sort of lobby for more funding, because it really shows the return on investment with the standardisation and reduced variation in care that you get by monitoring through a registry, and the return on investment you get by using that data. So a great report to sort of lobby for more funding. And the obvious reason why we have cardiac arrest registries in the pre-hospital space, for one, it's an easy to define, or relatively, condition. A lot of other sort of conditions like stroke, you have to wait till you've got the high hospital diagnosis, and so then you have to go back into your pre-hospital area to sort of work out which were true positives and which were true negatives. Cardiac arrest is a pretty clear-cut condition, and also it needs a complex care system. So if you're doing well in cardiac arrest, the assumption is fairly true that you're likely to be doing well in other complex conditions. Oh, going backwards, that's good. Last thing we need when we're running short on time. But they need to be sufficiently maintained. They have to adhere to definitions and be transparent in those definitions. And they need to collect outcome data beyond ROSC and survival to hospital. So our registry was initially funded by, we lobbied the health department. It now forms, and we now have over 100,000 cases. Like I said, it's now hitting its 20-year anniversary. We have over 100 ethics agreements with hospitals. We also have agreement with, we're just formalising another agreement with the coroners and with the death registry. But establishing VACA was a journey. I get a lot of people saying, oh, you're so lucky you've got such a great registry, but it was a lot of hard work, a lot of political lobbying, and we started when we had paper PCRs, and we used to hire uni students to sort through PCRs and say that one's trauma, that one's cardiac arrest, that one's pain. So you do actually have, it is quite a lot of work to establish it, but like I've sort of said to other services, we're more than happy to share our data dictionary, our processes, and even our platform, and we have had quite a few services visit us. Now that we have electronic patient care records, our cases are identified by electronic filter, but our data processes quality control every single field. We also have been doing 12-month quality of life follow-up since 2010, and that is really valuable data, and it isn't a big resource to collect it because unfortunately our survival numbers are not huge, but the use of that data is invaluable. And we do a significant amount of quality control on our data, which I won't go into, but there's a lot of field validation and random audits and senior paramedics auditing cases. And it's an evolving database, so as we move through the 10 steps and we find areas that we really want to focus on, we'll see gaps in our registry. So when we rolled out high performance CPR, we've now added key fields into the registry to capture CPR performance. We're really focusing on call taker and dispatch at the moment with the research program. So we now log into ESTA, our telecommunications authority database for all of our cardiac arrests and get whether cardiac arrest was recognised by the call taker, the time of recognition and the time of hands-on chest instructions. And we've just started adding some new fields around if a bystander did do CPR, what was their relationship to the patient and did they have any medical or CPR training. And this really helps guide our public education campaigns to see who's doing the CPR and who do we need to be targeting. And the common mantra, you can't manage what you don't measure. So to say that VACA has been instrumental in measuring and driving our improvement, so we've published extensively on various initiatives and used the registry data to validate those initiatives. And just to give you a very quick overview of how we use VACA to drive change, we use it to look at which initiatives are most likely to drive survival and what the cost of those are, and so what the cost-benefit ratio is likely to be. And we used that in the past to lobby government for various initiatives like rolling out fire brigade as first responders, having a public AED registry. You can measure the impacts of programs. You can do geospatial analysis around where you should be locating, like your fire responders or your AEDs or your lay responders. You can look at the impact of changing clinical practice guidelines and look at things like changing call taker instructions. So we have used the registry data at every point that we've made changes or to identify where we need to make changes, and it's been invaluable in that sense. And we also use it for internal clinical quality improvement. So we do a quarterly report that goes out to the regions and we adjust for things like response time and bystander CPR, and then see if there's still a survival variation in the regions. And that can be that can really facilitate improvement discussions. But, there are challenges in the pre-hospital setting. We have a lot of teams geographically placed across the state, and so looking at sort of individual team performance is really tricky in the cardiac arrest space because your sample size is so small. So it can get quite challenging to work out how you measure variation in care and keep it contemporary. So, so just to say that we do a lot of internal reporting to drive improvement, and this is just an example of how we'll present to the areas their adjusted survival rate and for all rhythms and then for VFVT. And so you can see this is a slightly old old data, but the point is that you can see then you would facilitate discussions with the grampians, like we've adjusted for, patient age, bystander CPR, response time, but still your performance is behind other areas. So since the establishment of VACA, one of the most important things is we have it embedded in normal business. So we have cardiac arrest survival outcome with our statement of priorities with government. That's a very smart thing to do because that gets board interested, and then your registry is likely to keep getting the funding and support that is needed. And we've now got quality of life outcomes in our what's called our PRISM statement of priority with government as well. So they're interested in outcomes beyond survival to discharge. And like I said, we use it to inform, we're about to write a new cardiac arrest improvement strategy, and we'll use the data to inform that. I'll skip through that. Now the other thing that is, and Judith will cover AusRock tomorrow, but there's now these sort of Epis Trees across the world, and there's similar challenges faced by Epis Trees and registries. So it's great when you get together as groups and discuss what those challenges are. So we actually got together in Singapore last year with the people from AusRock, PAROS, which is the Asian, Pan-Asian Epis Tree, CARES, which is the American Epis Tree. It has a significant number of American states contributing to it, and Eureka, which Freddie talked about, which is more of a research project, but it does give you a snapshot of what's happening around Europe. And we're hosting, AV and Monash Uni are hosting a similar meeting in October this year, so representatives from registries are more than welcome to come. And one of the good things about involvement in Epis Trees is that it really does allow risk-adjusted analysis of outcomes to see what services are doing better and why, and allows for that system analysis. But I have to be honest, I'm a chief investigator on AusRock, so I can say this: we haven't matured to that level yet. But one of the things that I really got out of it when we established AusRock was the different definitions and nuances that different services were using. And for example, we found out one service was excluding all patients that had resuscitation commenced, the resuscitation was short, decided it was futile, so they stopped resuscitation, and they were not included in their resus data group. So all those sort of conversations make you realise that benchmarking is really nuanced and really quite tricky. And we recently looked at our data and looked at the type of patients that we're strict about, we exclude, but I know other services internationally include, and they're patients who either receive bystander CPR but no public access defib, and they have ROSC when paramedics get there. You can't know that they're actually have ever been in cardiac arrest. Or patients where paramedics do like 30 seconds of CPR and they get ROSC. So we actually took those patients that we usually exclude and we follow them up to hospital discharge. They had like 81% survival because none of them were cardiac arrests. And so if you look what happens when you add them to your overall survival rate, it's inflated, which really highlights why we really need to use the Utstein comparator group when we're doing comparisons, because they're harder. It's a harder group to get definitions wrong in. And one last thing that we're doing in VACA, which I'm really proud of, and it's a great new initiative, it's been funded by the Dennisstein Foundation, whose son suffered a sudden cardiac arrest and died when he was only in his 30s. And this is the new unexplained sudden cardiac death registry, and it aims to recruit all cardiac arrest cases nationwide initially, but starting in Victoria in collaboration with VACA, from patients aged 1 to 50. And it'll be doing genetic screening on patients who've survived and died, inviting families in for genetic screening, and also referring survivors to a cardiac arrest clinic. And I think that's one area in research, which I'll talk about later this afternoon, that we've really, in terms of the chain of survival, that I think we haven't focused on, which is the sort of post-care of cardiac arrest survivors. So just watch this space for how that registry is going, but it's a great initiative, and I think it'll make a difference to quite a number of people's lives. So I hope that I did that pretty quickly because it's morning tea, but thanks very much for listening.